For decades, and in spite of persistent efforts to find and put people living with HIV on treatment, Nigeria was grappling with one of the highest rates of new infections and the third largest burden of HIV in Africa. In 2018, the National HIV/AIDS Indicator and Impact Survey, NIAIS, was launched, finally giving a nationally accepted estimate of the number of people living with HIV in Nigeria and how many of these people were yet to be placed on life-saving antiretroviral therapy, ART. More precisely, it told us where these people were residing. This prompted country and international HIV/AIDS program stakeholders, including the U.S. Centers for Disease Control and Prevention, CDC, and APIN Public Health Initiatives, to launch the HIV Treatment ART Surge, an ambitious approach that would dramatically scale up HIV testing and treatment services to put Nigeria on the path to epidemic control.
In the life cycle, they started what they call surge. Nigeria had about 600,000 patients on treatment, which happened over a period of like 12 years. And they gave us another 18 months to put another 600,000 people on treatment. And it was thought to be impossible. But the good news is that Nigeria, APIN being a part, met that expectation and actually exceeded it.
ART Surge program was launched in FY21. The activity started in FY21 in 6 states. And these states are Ogun State, Oyo State, Ekiti State, Osun State, Plateau State, and Ondo State. The aim of the surge, ART Surge, was to close the treatment gap for all these states. What do I mean by this? The US government planned to achieve epidemic control in these states, and an estimate of the number of people living with HIV across these states were known, and without these people not being put on ART, there will be problem. What do I mean by that? There will be transmission of HIV within the states. So the plan of ART Surge is to close the treatment gap, and to ensure that all the people that were supposed to be on ART were found and they are placed on treatment to reduce transmission of HIV in the states. Surge is really heavy on data, and we started by being able to categorize all the local government authorities in these states, identify the prevalence of all of HIV in all the states, so we could engage in targeted testing. It was really a tough one because all these LGAs are a different level of HIV prevalence. So it was now the task to identify which of the LGAs are really driving the epidemic. In other words, where exactly do we have people that are positives and are yet to be found? And that was a major task that ART Surge had to achieve.
To implement ART Surge in its project states, APIN developed many innovative strategies to find and target people living with HIV and enroll them into care. The first of these was moving from the facilities into the communities. APIN worked with the state ministries of health and state agencies for the control of AIDS to organize outreaches and then engaged trained community testers to bring HIV testing services to the communities.
In the last 1 year or thereabouts, there was that massive increase in the number of clients that we added based on the surge, intensified case finding. That's surge. We're going out beyond health facilities and getting to the communities, working with relevant stakeholders at the local government level to increase and optimize case finding, and that's what has been responsible for the over 8,000 that we had.
And that surge is what also led us to move into one of the local government that previously, we didn't have our presence in, which is SL, the local government in the state. And with such, SL being a riverine location in the southern part of the state, we were able to move into that LGA and been able to test people, and a lot of positives have been coming from that part of the state as well.
The ART surge implementation was not just about testing numbers. Equally as important as meeting surge targets was ensuring that the persons who were tested needed to be tested. In other words, their level of risk for HIV infection needed to be established. To do this, APIN's surge implementation relied heavily on data.
Targeted testing was implemented. Data-driven testing was also carried out. In other words, we use statistics such as mode of transmission survey. We also used what we call hotspot mapping. We used reverse testing strategy. We also used recency testing, which tells us flashpoints of new infection. So this recency testing actually came out big eventually, because as we were discovering where the new infections are coming from, we were able to target such area in such a way that we had a micro testing, and we're able to get more positives.
An important feature of the ART surge implementation was that it also targeted key populations who are drivers of the HIV epidemic. They have a higher risk of contracting HIV because of certain high-risk behaviors, which are commonly associated with this group.
For the key population, as we all know, they are drivers of the epidemic, and they are everywhere. However, they have their own special intervention strategies. So these were also deployed in these states, and then we were able to make a lot of progress in finding all the key population typologies, and we have their record also kept. And we also follow them to be able to test their partners.
APIN worked with the state agencies for the control of AIDS, state ministries of health, community-based organizations, and key population groups to reach these groups not only with HIV testing, but also with comprehensive treatment and care. This led to the setup of key population one-stop shops, where key populations could receive tailored, comprehensive health services, mental and psychosocial support from well-trained health providers without being stigmatized or judged.
For the key population program, we had a fund, KPIF, and we were able to open up some one-stop shops. There's one that is particularly known as the Center of Excellence, where we have staff that were engaged to be there, and we have some CBOs, community-based organizations, that we also engaged to be able to find cases in the community, because penetrating the key population community is not easy. So we had to find their peers who form the community-based organizations to be able to reach out to them. The men who have sex with men, we have some CBOs that are focused on that. We have some CBOs that are focused on female sex workers. We have some CBOs that are focused on people who inject drugs. And this has actually been very helpful, because we use their community facilitators to be able to get their peers from the community to bring them to our own facilities, the Center of Excellence. We had to seclude that because of the issues of stigma and discrimination against the KP. So we provided a one-stop shop where they come to, they are tested, they feel very comfortable at home, and then when they are positive, they are placed on treatment. For those who test negative and they meet the criteria, we place them on what we call PrEP, pre-exposure prophylaxis, in order to prevent them from coming down with the HIV infection. And then counseling, adherence, and all other things are being involved in that one-stop shop, where we monitor them for viral load, we ensure that they are retained. We have a call center there where we call them from time to time to know how they are doing, and and then also remind them of their appointments, and viral load monitoring and other treatment monitoring appointments, so that they keep to that.
It is important to note that ART surge did not only result in finding positives, but also ensured that those found were enrolled into care, retained on treatment, and supported to achieve viral suppression.
I want to talk about Surge again in the sense that it is not just about case finding. During Surge, as we are finding new cases, we also want to be sure that we are not losing the clients on treatment. So ART Surge program looked at the 3 cascade.
When we launched the Surge by the Executive Governor of Benue State in 2019, we were able to place over 91,000 clients on treatment. We were at 141,000 active patients in our program, but with the Surge coming into place, we've been able to place 91,000. At the moment, we're at about 232,000 clients that are active on treatment. And not just that, we've also been able to retain these clients on treatment. We had an interruption in treatment rate of about 5.3% and above, but right now we are at 0.6% interruption in treatment, which is quite incredible.
APIN, through the project, the Icares project, built in them a sense of worth, of confidence, to make them come out to seek their health and then stay healthy. For the ones who are living with, stay positive and healthy. For the ones who are negative, stay negative and healthy.
The results from APIN's implementation of the HIV treatment ART Surge is proof that we can achieve epidemic control and meet the UN AIDS targets by 2030 if we let the data guide us.
Nigeria had about 600,000 patients on treatment, which happened over a period of like 12 years. And they gave us another 18 months to put another 600,000 people on treatment. And it was thought to be impossible. But the good news is that Nigeria, APIN being a part, met that expectation and actually exceeded it.